Why do you believe we have a rise in diagnosis around ADHD, autism in recent years?
Uh, it's not just ADHD and autism, but that's the one that has achieved quite a lot of prominence. But we're seeing a rise in a number of other so-called diagnoses. I can explain later why these are so-called. They're actually not diagnoses. So depression, anxiety, post-traumatic stress disorder, bipolar disorder, they've all been going up. And they have been going up for a while, but they certainly had a big uptick as we came out of COVID. During COVID, interestingly enough, we actually had a drop in referral rates, I guess a bit like other branches of healthcare. People were rather wanting to stay at home. They didn't even want to do like online sessions, which was on offer. And then they suddenly jumped up as we came out of COVID. So a big psychosocial event affected in some way how people perceived themselves, particularly as they came out of the enforced isolation. But I think the seeds of this has been set long ago. So one of the things that I've been trying to help people understand in my recent book, Searching for Normal, is that when it comes to what we consider to be mental health and what we consider to be behavioral difference, we literally don't know what we're talking about. And I mean literally, we don't know what we're talking about. We don't know what we're talking about because if you look at any definition of what is mental health and therefore what is considered to be mental ill health or mental disorder, they are all subjective. So at its root, they are very liable to interpretation. This is an important difference to understand. We talk about mental health, we talk about them in journals, we talk about them on the news, in media, as if we know what we're talking about. So there is a big mismatch between what is being advertised and what is being sold to the public, as if there is something concrete, knowable, definable, characteristic about these different states that we're calling diagnoses. And this is an essential difference between definitions that we have in mental health and behavioral difference and the definitions that we have in physical health. Now, there are a lot of issues to do with physical health, which a psychiatric and psychological perspective can really help with, because healthcare involves relationships with your health caregiver. So it involves things like trust and things like level of understanding, but also particularly long-term health conditions involve changes in your psychosocial world. You have to make adaptations. So this is not an argument that says we can categorically define mental health and physical health as if they're absolute differences. There are huge overlaps, but there are some essential differences that it's important to appreciate and understand. So when you're defining something like diabetes, for example, you won't rely on a description. So if I, as a doctor, said, oh yeah, diabetes is going to the toilet a lot to pass water, being thirsty and feeling fatigue, I could be struck off as a medical practitioner, because that's not how you define diabetes. And there's good reasons why you would not define diabetes, because diabetes itself could present very differently. It could present, particularly type 2 diabetes. It could just present with vague symptoms like recurrent infections. It could present with no symptoms. But also lots of other conditions might present like that. Even psychological causes could present like that. So, for example, we've got a culture right now of everybody taking a bottle of water with them everywhere they go. Didn't used to be the case when I was growing up. So people are sipping water, and I've had young people come and they're worried that they've got diabetes. And I ask them, why are you worried about that? And they say, well, I seem to be thirsty and going to the toilet a lot. And I've looked it up, and it seems to be a symptom of diabetes. And of course, they don't have diabetes. They're just sipping water a lot and therefore going to the toilet a lot. So you don't define diabetes like that. How you define diabetes is blood sugar that is too high. Because if you have high blood sugar, it has certain effects on the body. But basically, you've got a physical parameter that you can measure that's external to a description. So you can take out subjectivity. Now, there are still huge debates that happen within the world of diabetes. Where should we put the cutoff? What is the best way to measure it? Do we just do it on fasting blood sugar, which is like a minimum of 8 hours after you've eaten? Or do we also look at sugar in the urine as our... So there are different ways and different approaches to thinking about the boundaries, as well as different approaches then to how much would you treat with lifestyle, when should you introduce medication. So these things don't take out all of these other interpretive debates, but you have something concrete, something physical that exists in the material world, if you like. Now you contrast that with definitions that are mental health. So you take something like depression, for example. I'll come back to ADHD, which is a classic one. Depression is defined not by any physical parameter like that. You can't say depression is a lack of serotonin, because we've been researching, looking for serotonin levels and serotonin imbalances. And there was a very widely quoted paper from a colleague and friend of mine a few years ago, which looked at all the decades of research around serotonin, and the conclusion was there is no evidence to support that theory. So you don't go and you don't get a brain scan, you don't get a blood test. How you diagnose depression is based on the description. A description related to low mood, negative thinking, feeling guilt, etc., etc. Now, a description cannot cause itself. You can't say that the cause of my low mood is depression. It would be a bit like saying the cause of the pain in my head is a headache. A description cannot cause itself. But that's what we've got with psychiatric diagnoses. They're all based on descriptions. They do not point to a cause, but we treat them as if we do. And the problem with that is that you're setting the seeds for potential concept expansion. When you've got something subjective, it can expand in a number of ways. So it can expand horizontally. This means that it can take in lesser extremes of experience, lesser lengths of time of having that experience. So it can introduce lesser states of distress, if you like, or lesser states of behavioral difference. But it can also expand vertically. And, if you want and you have time, I can give you 2 examples of how that happens. Expanding vertically means it goes into populations that weren't previously considered to have this condition, who are now introduced into that condition. For example, going from a condition that's predominantly thought to affect children to going into the idea that it's lifelong, or going from a condition that's predominantly thought to affect males into a condition that is now thought to also affect a lot of females. So that would be 2 examples of moving into new populations. And this is exactly what we've seen. That at times of psychosocial stress in a society, these mechanisms for expansion are there, ready to go into the states of distress that people are feeling, and to effectively medicalize them.
The what you're talking about is a very clear, in my mind, a very clear differentiator between how we're diagnosing between the mental and the physical, that we can objectively anchor ourselves onto something physical, and then anything that's a mental diagnosis, it's far more subjective, with symptoms ranging vast and wide. But one thing I'm really interested in that you've said there is what I see is the idea of holding on to that diagnosis. And so if you have a physical diagnosis that is something that is treatable, and you can move past that ill physical health in a moment or a time in your life, is that for some reason, or do you know why, that we hold on to any sort of mental diagnosis for a lot longer? Or is there a way in which we can actually move past that diagnosis, the treatment, and then continue with our lives? Do you kind of understand what I mean? Is the example I would give is, if I'm depressed for a period of time, if I have been clinically diagnosed with depression, are you then depressed for the rest of your life? Or can you move past that diagnosis and then continue on with your life without that depression and just it being a moment in time?
That's a really important question. And it relates to how, so one of the things that I wanted to try and understand further, and it's part of, if you like, the more speculative aspects of writing this book. So one thing I can say that I don't think is speculative is just what I've explained, that mental health definitions are subjective. That's just a fact. It's clearly there. Another thing that I've kind of hinted at in my explanation just now is that what we call psychiatric diagnoses are not diagnoses, certainly not in the medical sense, because they don't point to a potential physical process or cause, at least a proximal one. They are based on a description. So a description, in philosophical terms, has a different ontological basis. In other words, it's a different type of classification. It is not a diagnostic classification. So when we call it a diagnosis, we assume that we've understood a cause. So when we call, you've been diagnosed with depression, we assume that is the cause of your low mood. But as I've explained, that's a form of circular thinking trap. So these are things that I think are factual. But then we have to try and understand what might be driving some of these expansions, and how have we ended up with conditions like, for example, ADHD and autism that started out their clinical life as very rare conditions, predominantly as a diagnosis given predominantly to children. In autism's case, it was a very rare diagnosis, and it was predominantly given to children who had significant learning difficulties. So the sort of children that found it hard to, weren't even intellectually able to attend mainstream schools, for example. They tended to be taught in special educational settings. Many of them didn't develop language properly, or had various peculiarities of language, like something called echomania, where you would just repeat back the things that people said to you. So that's how it starts out its life, a very rare condition. ADHD starts out its life originally as something called hyperkinetic disorder, at least in this country. So hyperkinetic disorder, excuse me, again, was considered to be very rare. If you had learning difficulties, you automatically excluded somebody from getting this diagnosis, because it was assumed that your learning difficulties was the explanation for why you found it hard. You were on the go all the time. And you find it hard to settle and focus. So then it expands into the concept of ADHD, which comes from America. And it comes from America, and it seems attractive because there was this idea that there was a specific type of medical treatment, which was actually amphetamine-based substances. And amphetamine-based substances that were thought to improve your behavior. ADHD then comes in, but it goes into ADD to start with, which is attention deficit disorder. Again, considered to be fairly rare, small percentage of children. And the focus moves from being hyperactive to having difficulty with attention. So here's your first example of a sideways, a horizontal expansion, different behaviors coming into the definition. This is not because anybody had discovered any new biological or anything, any new genetics or any new neuroanatomical differences. This is a conceptual change. And that's what's happened with autism, ADHD, and all of these conceptual changes. So the next step is that ADHD is the next development from ADD. So I was training in the as a child psychiatrist. I first trained as a doctor, then a psychiatrist, and then a child psychiatrist in the early to mid 1990s. And I was with a consultant who was very interested in this new concept coming from the US, this ADHD, and wanted to do some research. I was working in East London at the time, and we had a high ethnic minority population. And there were a lot of kids from an Afro-Caribbean background, and they were much more likely to be excluded from school. So he had this concept, maybe that's because they have this condition called ADHD. So I readily agreed to go off and do a literature review and waded through hundreds of papers and all sorts of books and summaries and reviews. And I had that experience of, the will o' the wisp, where something appears in the mist, and every time you move forward to it, you think you've seen it, but there's nothing there. So that's the will o' the wisp. So I was going through all this literature and trying to figure out, so what is ADHD? And that's when I began to realize that there was an assumption that these behaviors represented something, that the behaviors that describing ADHD represented something specific. So this was upside down science, because what you do in science is you start with a hypothesis. You start with a hypothesis and you assume your hypothesis isn't true until you can demonstrate sufficient empirical evidence to support the hypothesis. It's not the other way around. You don't start with assuming your hypothesis is true and then look for evidence to confirm that it can't not be true. You start the other way around. So there was this was up. I realized quite quickly, once I'd gone through all these papers, that this was upside down science. How are we assuming that these behaviors equate to something specific, biological, neurological, potentially genetic, whether it's a disorder or a difference, before we can present any evidence that this is the case? So then ADHD expands. So by the 2000s, it was entering into it was ADHD in children had become common practice, and now they were talking about 3% of children, maybe. And then the concept that actually it's a lifelong disorder starts to come in. And so by the mid-2000s, this concept of adult ADHD was beginning to gain traction. About 10 years later, by about 2015, by the way, the criteria had to change for adult ADHD to come into being. So, because up until then, it was assumed that most children grow out of being hyperactive and impulsive and so on, and sort of settle down by their early 20s. And in fact, most of the evidence suggested that was, in fact, the case. But when you introduce the idea of adult ADHD, you started to focus back again on attention. So the concept was, adult ADHD just presents differently when you go into adult. Again, no evidence, no biological evidence. These are what I call construct mutations, and they are mutations. So what starts to come into view now is an idea that ADHD carries on into adulthood, but it presents differently now. So how it presents is in forgetfulness, losing your keys, being disorganized, finding it hard to keep relationships going because you're not reliable, etc., etc. So it's introduced kind of, this idea that you have a more chaotic kind of lifestyle. Things that would have never been thought of as symptoms previously. They're just kind of part of the spectrum of human behaviors. And then in about 2015, it expands vertically again by introducing the concept of masking or camouflage. So the idea is now you don't actually display these behaviors because you're really good at hiding them. But that's how you feel. So it introduces a concept, a new concept. Again, no evidence behind it. This is all conjecture. But why this concept really takes off is because the predominant psychiatric population in adulthood are women. So the concept of masking and camouflaging introduces a whole new group of women into the diagnosis. So this happens in ADHD, it happens in autism. Autism, by the way, has since also then expanded from this very rare to just take in what I consider to be our sense of focus on the idea of sociability. So autism just starts to absorb our increasing focus in a brand image-obsessed age on how sociable we are, how easy we find it to be in the company of others. And it's tapping into that sense of judgmentalism, of shame, of I'm not good enough. Really, these conditions are really tapping into those feelings. And so that one takes off as well. So what we've seen is this expansion, as I say, horizontally and vertically. I've just given you a very brief summary of how those mutations happen. And the important thing to understand is at no point has there been any, even though it's been researched and researched and researched, nobody has found anything specific, characteristic, identifiable at the biological level that differentiates people who have these diagnoses from people. These are really invented categories. And then to get to your question, I know this is a bit of a long preamble just to set the scene about, how these, when it starts coming into the whole thing of ADHD, autism, and the concept that these are lifelong disorders, it starts to merge, in my view. This is one of the things I've proposed in my book. It starts to merge with identity politics. It starts to merge with a movement that developed when essentially the left-right division, if you like, dropped class, dropped socioeconomic difference as the place where they have their disputes about how best to organize an economy, how best to organize a society. Thatcher's famous words when she was asked, "What is your greatest achievement?" And she said, "Tony Blair." And she was right. They dropped classes so now left-right politics was around entryism, what I call entryism, getting more people from different backgrounds into the higher levels of society, not these kind of socioeconomic structural issues. And so the idea of what I think what it, I have some problem with the whole concept of woke, but it's kind of that sort of sense of we have all these disadvantaged groups and we kind of end up with a Olympics of who's more disadvantaged than the other, whether it's based on your sexual orientation, on your ethnicity, and brought into that is this idea of you're neurodiverse or neurotypical. So once you've introduced the concept that these are lifelong conditions, you start to introduce the concept and sensitize people to the idea, oh, maybe I'm struggling. I feel like this because I've got this disorder and I can't help it. So I don't think people are sort of, if you like, intentionally giving up on the idea that they can do something about and change and shift. I think that's what they've been fed. I think we've sensitized the population to this idea that there's a group of people called neurotypical. I don't know how you're meant to identify. And there's a group of people called neurodivergent. And if you're neurodivergent, the workplace doesn't fit for you. And they're not making accommodations for you. Just like, and it's just like gay rights or racism or all of these isms. So you've got something now introduced called ableism. And it's pushing towards an idea that what we need to do is make society more friendly to these groups of people by adjusting workplaces. And so if workplaces don't adjust, so it kind of by default becomes easier to blame your workplace for being ableism unfriendly or whatever you want to call it than it is to maybe see what you can do to improve or change. I mean, it is happening at the same time that workplaces and places like that in society have really become very tough. They have, in times of economic insecurity, that tends to be what happens. You got, unemployment, increasingly people having to hold down 2 jobs and etc. But by doing it this way, we shift the attention away from actually these, what I consider to be more economic, socio-structural, political problems, and it becomes easier to shift it into these are individual types of issues. So about how employment friendly you are, rather than how much the system is hard to survive in this way, and that we should really be looking towards our politicians to be making these changes.
Mm. This comes to the heart of actually what a lot of this for me is why I find it fascinating, is because there's so many directions you can go in, but the constructs that we've come up with and the fact that we're saying that society is not essentially molding itself to accommodate these diagnoses or different conditions along the way is where I really start to find myself getting frustrated at it, because if we take diversity as a concept, it just will never end. because every person on the planet is diverse by definition.
Exactly.
And we have to at some stage anchor ourselves in some form of normal and some form of generalized population rules and regulations that we have and ways in which we behave in society. But I come from this from a personal point of view. So people listening to the show, my condition, Poland syndrome, means that I have a physical condition which impairs me in some way, shape or form, but doesn't incapacitate me. So it means I'm missing my right pectoral muscle, 2 ribs directly behind it. For example, the analogy I always give is if I go to the gym, if I'm to do a bench press, I can't use a barbell bench press. I couldn't have weights on the left and weights on the right because I physically cannot push as well on my right as I can on my left. So I use dumbbells. And if I'm doing a bench press, it looks kind of ridiculous. I'll have a 40-kilo dumbbell in my left hand because I can push that. But then I'll have like a 20, maybe a 25-kilo dumbbell in my right. And my shoulder's doing most of the work there anyway. But if I was to look at my condition and go, how does the world mold to my condition? It would be me turning up to the gym and looking at the gym dumbbell rack and going, how inconsiderate. They've put the 40-kilo dumbbells all the way over this side and the 20s are all the way over there. And they've not considered to put the 40 and the 20 together because that's what I need. And that for me is where I say you have to recognize that if you have a condition, if you have some form of diagnosis that slightly incapacitates you in the world that we live in, we have to move as a collective, and therefore it is your responsibility to find a way in which you can find ways to survive in the world, to thrive in the world as well, by using whatever capabilities you have to the best of your advantage. But we're completely flipping it. And I said to you pre-recording that when I grew up with my condition, everything I wanted to do was to find a way in which I could seek back to normal, into the ways in which everyone else was doing things. But I think right now we're doing it completely the other way, in which I'm diagnosed with a condition and I want to move further away from everyone else and isolate myself so that people can either see me as different, see a way in which they can mold the way in which the world works to me and to help me. And that then leans into this lack of accountability for what you're doing, maybe a victimhood mentality, and in my opinion, a lack of resilience in dealing with the stresses of the world that are in front of you. You're unable to deal with any challenge that's in front of you because as soon as life or another challenge hits you, you're going, well, how's it going to change for me so that I can deal with it? And I guess my roundup question to this is like, why do you believe with all of this, we've become so adverse to some form of mental pain in the world?
That's a question that sits on many different levels, because there is the level of the individual that you're highlighting, and there's also then the level of the material world in terms of, what's going on in terms of our socioeconomic world. But there's also that level of what are the ways of thinking that we're encouraging. Because how we imagine, how we interpret our experiences has a huge impact on how we actually experience. So there are so many different layers to what you've just introduced as something to try and understand what's going on. I agree with much of what you've said, and I do think we are shifting further and further towards a situation where a lot of people have been, and I think they maybe don't realize because they passionately hold on to these views, that they're being disempowered. They're disempowering themselves, but it's because we've introduced these concepts like I've been explaining. which are disempowering in themselves. So the concept that you have this lifelong condition, for example, autism, and because you have this lifelong condition, it makes it difficult for you to do all sorts of things, or that you have ADHD and it makes it really difficult for you to hand in your work on time or whatever it is. And me as a child and adolescent psychiatrist, one of the things I've really worried about is the impact this has on children growing up. Because one of the things that I explain to young people and to parents who are worried about their children, and I don't see parents who are kind of there trying to, they come seeking a diagnosis or seeking because they've been educated to think that there are all these conditions going on in the young people. But when one of the constants about young people is that change will happen. Actually, that's something that's constant about all our lives. Change is the one constant as we move through life, but it's particularly the case during adolescence. So during adolescence, during childhood, but particularly during adolescence, you're going to change your interests. You're going to have emerging sexuality. You're going to start feeling things in a lot deeper way. Your friendship group might change. Your ambitions might change. That change is the one constant. This idea of fixing people into that they've got this condition and that this condition is potentially lifelong, it's profoundly disempowering, because you start interpreting some of your experiences and some of your behaviors as if they're a sign that there's something wrong in you, and something fundamentally wrong in you that cannot be healed or changed or influenced in some way by yourself or the people around you.
Does it bring on like a learned helplessness?
It's a type of learned helplessness, because you start to interpret your experiences as there's a part of you that shouldn't be there, that you should try and suppress, or you should try and get rid of. And if you can't, then you are basically, that's what you have to live with. But you've already sensitized people to this idea that there's something in them, something fundamental, something potentially wrong, something that's going to make things difficult. A colleague of mine, an Australian psychiatrist called John Uredini, wrote this lovely paper that really, just in the title, emphasizes the importance of something. The title of his paper, which caused a lot of controversy in Australia, he's a child psychiatrist as well. The title of his paper was "Let Your Children Cry." And what he was arguing was that our job as parents is not to try and protect children from all these stresses and the struggles with growing up. Because if we do, they're not going to be enabled to discover that you can live through adversity. That is part of growing up. That is part of deepening your psychological sense of yourself and of the world. Our job as parents is to be there, support them, be patient with them, and allow them to go through these struggles without imagining that we need to sort these things out for them. That is how we discover resilience. Resilience, there's this trend that you can teach resilience. To me, that's nonsense. Resilience is an experience. Teaching is a cognitive thing. You only discover resilience by surviving adversity. So this is, again, something that I've been talking to trainees, and I've done a lot of training, both because I'm a psychotherapist as well as a psychiatrist. And one of the things that I emphasize to people is stories of suffering are also stories of survival. And we can choose to nurture. I think we should act as witnesses for suffering. So we need to validate, we need to understand, we need to listen. But we can also be part of the process of helping people understand how they got through some things, how they're still going. And then you're kind of nurturing different aspects of the person. There's too much, in my opinion, in terms of both psychiatric and psychotherapy culture that has escaped the clinic room and is now spread all around our societies, almost like a virus. So people are using words that were only ever used in the psychiatric clinic. They're using concepts that were only ever used in the psychotherapy world. And it's creating this sense that we're all vulnerable. So it's creating a model, if you like, of human nature that emphasizes primarily vulnerability. If you look at societies and cultures, because that's been another interest of mine, is looking at concepts of childhood, child development, family life, and personhood, and concepts of self. If you look around the world in other cultures, and particularly more collectivist cultures, they've had to deal with far more adversity in their lives for all sorts of reasons. But many of them don't seem to be struggling with these concepts of focusing on the bits that are going wrong. There are lots of ways in which, as a society, you learn how to deal with, cope with, and emerge from, and find strength in. So we've got a lot to learn from other cultures who've had to deal with adversity, because I think one of the other things that has happened, and this is sort of approaching something that you could consider more at the societal narrative level, and these all affect how we then interpret our experiences, is our concept of risk and vulnerability is another thing that has had this concept expansion. The concept expansion horizontally and vertically, as I've been, because the idea of trauma, the idea of adversity, is also pretty subjective. So, for it, just to give a few examples, the idea of vicarious trauma being introduced. So the idea, if you see a trauma, like this idea that doctors who were working in COVID were experiencing vicarious trauma. Again, you're emphasizing something, and you're sensitizing people to parts of their experience. Of course, it's distressing. But there were more parts of that experience because you're also on the front line, you're doing something to help people, so there are other parts of that experience, again, stories of suffering and stories of survival. So we've had these various expansions. So the concept of trauma itself has undergone quite a lot of expansion. And again, it sensitizes people to aspects of themselves, and then they understandably focus on those aspects of themselves and become troubled by these, and become troubled by the idea that there's something that they need to, that's going wrong, that they need to address, and that other people are not understanding or accommodating them. And this is what you're referring to as something of the victim mentality. I don't blame people for having that. This is what we are advertising.
Do you believe that any of these diagnoses, though, bring a form of relief to those that are getting them?
It does. I think there is a lot of evidence from just people themselves who are saying, oh, now I've understood myself. Now I understand why I can't do this or that, or why this is happening. And possibly that might enable them maybe to make some positive changes. However, I fear that it's a kind of a cruel kind of hope that's being offered. So this is where I now think these types of diagnoses operate more like commercial brands. So I no longer call psychiatric diagnoses, I call them brands. So like most commodities, the things we buy, we often buy things because we imagine, and it's been advertised to us, that it will make our life better in some way. You know, the latest car, latest TV, I don't know, you know, all sorts of things. But after a while, it doesn't, you know, these material things don't tend to improve our lives as much as, you know, the old doubts creep in and we want the next newest thing. We want the next newest thing. Now, I see that process has been happening with these concepts. So I've seen it even in young people, and I've seen it in adults as well. But I found this trend really disturbing in young people. So they'll start with an idea that they have, for example, I recognize features of autism, the way I'm having trouble with friendship groups, or how I fall out, or loud noises, or whatever it is. Oh, what a relief. Now I understand why I can't do this, can't do that. A few months down the line, a year down the line, yeah, but there's something more than autism, isn't there? There's something else, there's something deeper. I think I might have bipolar disorder. I think I might be in the wrong sex body. I should have been a man. That's why I'm feeling like this. And I've got an anxiety disorder. So I've seen young people, when I've asked them to describe themselves, they've listed that they're ADHD, autism, bipolar, PTSD, anxiety, depression. So this is what I call the cruel. None of that is really addressing something, but they're falling deeper and deeper into this rabbit hole where they imagine there are all of these things going on and they're trying to be proud about themselves. But actually, for me, when you fall into this rabbit hole, you've actually done the opposite. You're not accepting yourself in all the wonderful diversity that you have, just as you are. You've set yourself into an idea that there's something that's you and all these other things that are also you, but they are not you. It's a very disturbing trend, and it's not going to solve people's anxieties, and those feeling better tend not to last very long.
I'm really fortunate that I get to go and be asked to do keynote speeches to talk about my story of how I overcame my condition to make it in professional sport. I get paid to do that. And the funny thing is that the reason I get paid to do that is because the story I'm telling is how I have this condition and I found a way in order to deal with the world around me. And what you're describing is people are choosing to almost revere themselves and create this self-revering story, or whether it's, again, main character syndrome and trying to be unique in the world and say, well, because I've got this condition, now I'm unique and I'm a little bit special. But that's not what society would revere. It's not what you wouldn't get someone paid thousands of pounds to go up and speak in an event to say, I was diagnosed with depression, and then the story ends. And then and my life just became horrendous. I have seen keynote speakers do that, where they have said, I had depression, and then I got through it, and now I see life beautifully in colors, and I experience the world differently. And it kind of goes back to what I said earlier, is finding your way through that period of life and come out the other side, and as you said, being a survivor of that trauma. But I think we are holding on to the wrong part of the story, of the diagnosis being this weight that's pulling us down and pulling us back. And then from that, it just makes the rest of human experience really difficult. So is there any part of some form of diversity or diagnosis, whether it's neurodiversity or any other condition that's associated, where it actually becomes valuable, and or does it just purely become another label that limits our human experience?
Well, I think you touched earlier on the idea that diversity is simply a statement of the uniqueness of everyone. So this concept of neurodiversity, it's a strange concept because it wants to divide people into a group who are called neurodiverse and a group called neurotypical. Now, nobody's found any evidence of the neuro bit, so all you've got left is some people are diverse and some people are typical, which is clearly nonsense. We're all diverse. We're all unique neurologically. So to me, this obsession with the idea that we need to find a little pigeonhole to stick ourselves in, not only is it not compatible with the ultimate uniqueness of every person on this planet, which I think is marvelous. I think there's something marvelous about. We're all unique genetically. We're all unique in terms of our experiences. No two persons are going to be the same.
I would interject there and just say something that comes to mind is how much we revere and we appreciate that concept when it comes to the Paralympics. So when you look at the Paralympics, and I've spent time with Paralympians, when you see them, everyone thought, how amazing is this? You see people that from a vast range of different conditions, and it's celebrated.
Yes, and it should be celebrated, that uniqueness that we all have. And if you so the Paralympics would be a good example of people who are doing what you did. They've got certain limitations, and we all in our lives have certain things that are going to be limitations in terms of what we're able and can do, whether that's limitations because of our bodily condition or limitations because of our sociocultural or the events that are happening around us. But we also have possibilities. Nothing is indeterminate like that. This is the thing that I worry these concepts are shifting us away from a much more fluid understanding of human nature. One of the things that human nature has is that we're always going through change. There are always possibilities. Of course, yes, there are many limitations, and we have to be able to appreciate those limitations, but we also have to be able to live and find out what those possibilities are within the limitations that we have within our own life. There's one of the famous therapists that who was also a psychiatrist, that whose work I found very interesting and very enlightening, is a psychiatrist called Milton Erickson, and you might look him up because one of the things that people have written about Milton Erickson is that they've said they couldn't find a kind of unifying concept of what his approach to therapy is, because it seemed to be unique for each person. And I remember this, one of the cases he describes is, or has been described, is of this person who was suffering with terrible arthritis. So much so, he was in a wheelchair. His hands were sort of frozen. he was unable to do anything, and the treating physicians thought, maybe we'll pass it on to Milton Erickson, had a kind of reputation of dealing with these, very intractable problems. And so Milton Erickson talks to this guy and says, I want you to practice moving your thumb. I want you to practice that. And until you've practiced that, I'm not going to see you again. Until you can move your thumb, I won't see you. I won't have another appointment with you. So this guy is kind of quite angry about this. Anyway, he starts to move his thumb. He comes back for another session. Okay, I want you to move your middle finger now. Anyway, you get the concept. He wanted that person to start focusing on something he could do. He could find a way to get doing. Anyway, by the end of the treatment, he was out of a wheelchair. He still had a lot of, pains and aches, but he was out of the wheelchair. He was back walking. He was, so it's a lovely example of we can focus on the suffering, the problems, the limitations, but there are always possibilities.
That brings me to an interesting point, is how do we... What you spoke about resilience earlier, and you said I don't believe you can teach resilience, and I would agree with that. Where you're going with that, in saying that you can't just place resilience onto someone. And again, a lot of, whether it's me speaking or I spend a lot of time working with athletes, and I would say the number one thing that we're focusing on is resilience. So resiliency, whether it's in a moment, in a sporting context, resiliency out of that sporting context and dealing with life, or just dealing with life in general. And the method in which I teach it is by placing them in experiences. So the only way you take pressure in sport, pressure is a really interesting concept. So dealing with a pressurized moment in sport, a World Cup final penalty shootout, or hitting a match-winning putt in a Masters Championship, whatever it might be, you cannot practice that pressure or understand how to deal with that pressure until you have had pressured situations and you've put someone through training, you've placed them into a challenging situation. And the experience, I always say that the analogy I use that we've got to is that we've had a situation, whether it's through parents, coaches, that have this "I'll show you the way" mentality, which is they place themselves in front of the experience and show them how to do it, and I'll deal with it and help you do it. And then they move out the way, and then the experience hits the child or the individual, and they can't deal with it. Whereas I was fortunate that I believe my parents showed me I've got your back mentality, which is you go, here's what you should do, here's how you could do it, how you could deal with it. Go experience it, fall back, we'll catch you and deal with it. And all of my coaches did that, and you build resiliency in what you're doing. But I also believe you can do that to yourself, throw yourself into that situation. So what roles do you believe now, where we sit, whether it's family, coaches, guides, mentors, people responsible for young people, place or what their role is in overcoming this distress for young people?
Oh, it's interesting what you're saying about the coaching and the fact that people have to experience it. There's some things that are experiential. You can't teach it cognitively. It's so. I mean, that's a important principle over the years that I've developed in working with families. A lot of families come, and I hope you're going to tell them, for their kid who's worried or their kid who's not following instructions or not doing things that they've been asked to do, that I'm going to tell them, okay, do this, follow it by this, and then this will, or that in some way I'm going to see the kid and do some therapy and sort of get through to their, that I have some special way of talking to kids that they don't have because I'm an expert, etc. But actually, one of the things that I've been explaining to parents for years is that I can only give you a set of principles, a set of ideas, a set of ways of thinking, but I can't tell you how you're going to have to discover that. because I don't know you, I don't know your family, I don't know what works, I don't know how you're going to interpret any of this. And one of the most rewarding experiences in terms of seeing people make progress therapeutically has been when they discover. It's a bit like I'm explaining to them, you've got the knowledge, you just don't know that you have the knowledge. My job is just to help you understand that we've got the knowledge. There's no shortcuts to you figuring this out yourself. If I give you a set of principles or a framework, a way of thinking about, then you have to go and figure it out. And people do. And it's very empowering because then they realize they can do this. It's not an expert who was needed to tell them, to stand over them and say, do this, do that. Yet the person gave them the tools, if you like. And it's a bit like what you were saying. They have to discover that for themselves. It's not something that experientially you can sort of impart or absorb through osmosis into their minds. So remind me the question about as a society.
The role in which parents, and whether it, again, I think a lot of it does fall to parents at the moment, because I actually see as well with the newer generation of parents that come through, because that generation of parents are growing up with this mentality, whether it's this learned helplessness. So therefore you're going to have this second-hand helplessness that can be passed on. And so I say that because I have friends who are now parents and they're raising young kids. And while I do believe there's a pendulum swing that could happen, I do also worry that, yes, parents that have created labels for themselves and their own situation that will just hand that label over to them very quickly. So where do you see that role of parenting being placed in overcoming these diagnoses and actually moving forward with a more resilient mind?
Yeah, I kind of feel sad and sorry for parents who've had to grow up surrounded by this discourse of disorder and diagnoses. So I see things that might be able to shift things in a better direction in a number of ways. So schools have a big role to play. We need to take, in my opinion, all mental health awareness trainings out of schools. This has been very widely researched. We've got lots of mental health awareness classes and things like that going on in schools at the moment. In schools that provide these types of classes and interventions, they're more likely to end up with children experiencing distress, anxiety, depression, things like that. When you follow them up 12 months later, they're actually bad for kids. So that's something that we need to take out of schools, because that's just sensitizing kids to the idea that there may be something wrong with them. I think we need to take out all of this. I think we need to collapse the whole neurodiversity concept. I think it should be taken out of special needs education. It should be taken out as a reason for extra time in exams and all of these types of things. I just think we just need to take it out and go back to the idea that you do individualized assessments for special needs support. So these kind of incentives that create this booming number of people who are getting classified as having special education needs, it's expanding at an unsustainable rate.
I've seen that happen in schools as well. I've actually had first-hand experience of that, where you walk into a school again and you meet the teachers. I went back to my old school and I got to see my old teachers there, and bless them, they look like in the 10, 15 years that I've not been there or longer, that they've aged twice that, because you actually ask them about what their day-to-day looks like. And I've had teachers say that we are we are being used as not only as teachers for our job description to teach the subjects, but we're also chaperoning kids from class to class because they've got some form of phobia between classrooms that they can't make it there. So we have to chaperone them because of their anxiety. And you sit there and you think that is a child.
You're encouraging the anxiety.
You're encouraging it, you're enabling
Yeah.
it, you're
Yes.
protecting the child from actually overcoming the stress that's right in front of them.
Yeah.
And it's also not on their job description. And then if there's another child that happens, we need another teacher. And if there's another one, we need another one, until the point where it could be the entire classroom. And I mean, Abigail Schreier said this in much around her book, Bad Therapy. We're talking about this over-glorification of these small traumatic experiences that we have.
That's
where
what
if
I'm-
moving to a
Yep.
classroom to classroom,
Yep.
you glorify that. You don't just label it as a bad experience, it becomes a trauma. Therefore, the
Yeah.
school becomes traumatic. Therefore, you hate school. Therefore, you don't
Yep.
get educated.
Yep.
And it will spiral.
That's what we've been talking about, and that's what appears to be happening. Like I say, the concept of trauma itself can be expanded, just like the concept of mental health and mental disorder and neurodiversity and so on. Yeah, and I've come across some pretty startling statistics recently driving in Ireland. There was listening to the radio, they were discussing the fact that now 5% of children in their schools have a diagnosis of autism. Autism as a concept started with a prevalence rate of 0.04%, 4 in 10,000 children, very rare. Now talking about 5%. And how are they going to, I had a friend of mine in Scotland who had something to do with the education department up there. And he said it's approaching 40% of children who have some form of special educational needs. So this is going out of control. It's not good for schools, it's not good for teachers, but it's really not good for the kids themselves. That this type of concept expansion, sensitizing people to the things that they now start to think there's something that they can't do. So I encourage parents, don't let your children be labeled. Fight it every inch of the way. Be patient with your children. Remember that they are going to grow up. They are going to change. You cannot predict what they're going to be like now, what they're going to be like in their 20s, what they're going to be like in their 30s. Be there when they fall. Support them. Be kind to them. Be patient with them. But don't tell them how to get up. Let them discover how to get up. Those are the sorts of things that I also beware of the language that we're using. Don't let this kind of therapy, psychiatry language creep into. Children have tantrums. They don't have meltdowns. Meltdowns is a word that came from autism, this idea that they've got too much sensations. Beware of the concept of emotional regulation. That's another nonsense concept. It's emotional regulation. Emotions are emotions. We interpret the meanings of our emotions, but they're just emotions. Don't get so caught up with. And the number one thing I try to tell parents: don't try so hard. That is usually a pointer that they're getting concerned unnecessarily of something being deeply wrong. When you're concerned of something being deep, you start trying to do this, you start trying to do that. Let childhood happen. Let people grow up. Growing up is a struggle. I sometimes explain to the people I'm seeing, I really, really hope reincarnation is not a thing, because I don't want to go through adolescence again. Let it happen.
What would you start to conceptualize as normal right now?
So in a way, the title of the book is a bit tongue-in-cheek, because towards the end of the book, I say, I quote a sign on a T-shirt of a friend of mine that's in Spanish, that's translated to "Up close, no one is normal." So in a sense, what I'm saying is that we construct an idea of normal as a society, and it's based on our idea of what we consider to be human nature and what we consider to be outside of the realms of human nature. And essentially, I'm arguing our concept has got narrower and narrower and narrower. So we now have a lot of people. So our concept of parenting, coming back to the question that you just asked just now, you have the situation where you'll find the parents trying to rationalize with a 3-year-old that it's time to go home from the park, as if they can understand. So you get this peculiar form of cognitive parenting where you're treating children as if they're little adults already able to, reason and rationalize. And so so the idea of intervening as a parent in your children's life, being actively taking charge, that's become, now that's sort of out of the realm of what we expect parents to do. So in my book, I was saying these are all symptoms, if you like, at a societal, at a narrative level, that we're constructing a version of humans that's got very, very hard to find, very hard to fit into. And that's a problem. So my preferred language is that our experiences and our behaviors, broadly speaking, fall into the category of what I call ordinary and or understandable. And I prefer those words now. And if you take that as your starting point, so when people come to the consulting room, and I was a consultant for 30 plus years, if you start with that assumption, that's the sort of people you're going to meet. If you start with the assumption, oh, there's something wrong and I need to dig around to find the right diagnostic category to categorize, that's what you will find, because this is subjective. So my starting point is kids are ordinary. They're reacting to things that are going on. We might not necessarily understand why they react in the way, but at some level it's understandable. It's part of the ordinary spectrum of the way humans react to things going on in their life. Please resist the temptation to pathologize or medicalize it.
I also think an element of this turns to a sort of perspective that people have on life. And funny enough, being British, we have a very pessimistic view compared to an optimistic view. We're taught poppy syndrome and all sorts of ways in which we view the world. You place that into, say, and I know America is having its own problems, but America has a very optimistic way in which it broadly in the culture looks at the world. So it will see and revere people who are having success, and it'll pump them up and want them to do well. And while that is a generalization, I do think that the way in which people view their experiences, just by trying to move away from this pessimistic view to a more optimistic view, what can I find? What is the good in this situation that I can look for, and how can I find that? And almost, I'm not a parent, so trying to give parenting advice to friends when you aren't one is a challenging situation. But I always say, like, look, if you're talking to your kid, surely giving them the good in the situation, face the optimism, go towards the optimistic view. What can you find in that situation? And the lead into that as well is in my own personal experience and belief, and a lot of whether it's the podcast and my work that I do, I have this belief that we have spoken about mental health for too long, that we have spoken about it as this debilitating concept, this debilitating part of our experience. And actually we can change it to looking at mental strength and saying, how do we build our mental strength? The same way, if you were to get physically injured, and I've experienced many physical injuries, people are revered for rebuilding their bodies back to deal with life post-injury. And why can't we do that for our minds? Why can't we view ourselves as building the mental strength and capabilities and capacities to take on life, to take on the challenges? And then through that, we actually feel proud of ourselves. We enjoy life more. And actually a byproduct of that is that your mental health is probably in the positive. And so it's almost like focusing on the problem has created the problem itself, and therefore it becomes debilitating.
Absolutely, absolutely. Although, in terms of comparing us and America, actually, a lot of these concepts are probably even worse in America and across Western Europe.
As I was saying it,
Yes.
I recognize a lot of the literature and the academics come out of there. Yeah.
Yeah. However, coming back to this concept, first of all, on the idea that looking at people from the point of view of their existing abilities and strengths and what can they build on and what can they discover. When people get through difficult things and find a way, they discover parts of themselves. They kind of grow psychologically when you get through a difficult experience. I've had seen people in the most dire of situations, really struggling, unable to function, and I've seen them find a way, recover, go to university, get on a training scheme to become a pilot, or just find their way out. People do have the capacity. So let's be careful not to short circuit that capacity. And you're really right that if you focus on the problem aspects for too long, it reinforces itself. So one of the things that I have come to believe is one of the I don't know how big a part of causing our mental health epidemic crisis, our crisis in mental ill health, I think is the concept of mental health itself. So I argue that there is a process that I call the problem becomes the problem. And one of the ways I explain that is if you take something fairly ordinary like insomnia that most of us experience, initially we might try various things, but if we keep having insomnia for night after night, eventually the thing that keeps us up at night is whether we're going to have another sleepless night. So at some point, insomnia starts causing itself. And if you now try to solve it with changes of routine and some whatever, and it goes away for a bit, but then it comes back, you're going to be more convinced that, oh, this was a bigger problem than I thought. You might go to a doctor. You might get a sleeping tablet. Sleeping tablets tend to work pretty well. But after a few months of taking them, they don't work quite as well because your brain habituates to it. So you're now basically on the circuit towards reinforcing every time. But if at the start you hadn't fallen down this rabbit hole and thought of insomnia as, okay, it's something that happens. It's something that happens in my life. I've had things on my mind. It's just part of the human condition. I don't like it when it happens, but it's not a problem that needs a solution. It's just an irritation. Once you've classified it as a problem needing a solution, and you end up going down this road of solutions come, but then they don't work, you're going to reinforce this process. So replace the word of insomnia with depression, replace it with anxiety, replace it with ADHD, whatever, and you'll see how this reinforcing process can develop. the more you focus on an idea that you have a problem that needs a solution, and that solution either doesn't come or comes and then returns, the more you're reinforcing that process. And there's another nice way of working that I think further adds to this idea. Let's focus on what you can do rather than the bits that are problematic. It was developed by a friend and colleague of mine, a Finnish psychiatrist called Ben Furman. And he basically comes up with this very simple concept that we're all born with certain skills. Some skills we find quite easy to learn, and other skills takes a bit more practice. So redefine the problem as a skill that you're having a little bit of trouble learning, and let's figure out between us how you might learn this skill. Let's get some routines. Let's invent a routine. Let's film it. Let's decide what would be a success in developing. So it might be just something like, the problem is that you're losing your temper. Okay, let's think of that of a skill. What happens when you're angry? What could you do else? Okay, let's practice it when you're not angry. What would that look like? How are we going to celebrate the success the next time you? So this again flips the idea that this isn't a problem we're trying to get rid of. It's a skill we're trying to learn.
Do you think we do have a path back from all of this over pathologizing of the human experience, or do you think we're kind of set on this path right now, and this is what we're going to be having for a little while?
It still hasn't run its full course because there's a lot of money to be made, and we are in a society that is, very marketized. So there's a big market for it. But we're now getting to the stage where politicians are also saying, well, we seem to have created systems that are just unsustainable. So whether that's in terms of the big rise in people who are claiming disability benefits, that is nearly all down to the rise is nearly all down to people who are experiencing have diagnoses of mental disorders. The big rise in special needs education, again, that's nearly all down to mental health and neurodiversity. So we are in a situation where there is I think we started this conversation earlier by pointing out that people are scratching their heads wondering what the hell is going on. Where are all these massive increases in people who are kind of identifying as neurodiverse, in the numbers of people who are saying that they have an anxiety disorder, depression? So this is not people purposely doing that. It's we've created the conversation, we've seeded the ideas that's leading people to identify in that way. But now, as a society, we're scratching our heads wondering what the hell is going on. So there is the beginnings of something that might start pushing back. I think if we're really going to push back properly, we actually need to go back to talking about class, talking about socioeconomic conditions and the insecurities it creates, and actually challenging some of the vested interests that keep this current economic system that embeds and inflates levels of inequality. Because at the moment, the things that none of our politicians want to do is to challenge the power, particularly of the financial sector.
Have you had any pushback on the publication of the book, concepts within the book, a lot of what you're talking about, whether it's from inside the psychiatry industry or psychological industry? Have you had much pushback on what you're proposing?
I did have some pushback from my place of work, which was part of the reason why I thought, oh, I'm not likely to retire, so I might as well retire. So there are certainly people within psychiatry who find these views difficult. But there are plenty of people within psychiatry who don't. So I'm co-chair of something called the Critical Psychiatry Network, and we have, I think, nearly 500 doctors, not just psychiatrists, but GPs. And so within the profession, there is also a lot of skepticism about what is going on. But what I do find is that with many of the other professions in mental health, for a long time, they've gone on the coattails of psychiatry, particularly of psychology. But there's increasing numbers within, for example, psychology and the psychotherapy world who are actually saying, yeah, there is something fundamentally wrong in the way we're approaching what we call mental distress, mental ill health, mental disorder. And I suspect that I am in the majority opinion if you took at mental health professionals as a whole. And actually the mainstream is now increasingly representing the minority opinion. But they're the ones with the power.
Yeah, that seems to me there's these small giant forces that are pulling these concepts, and then I don't know whether it's our sort of biology that and our negative bias within our brains that wants us to move towards these concepts much faster than the actual hard work. It's kind of like this argument around Ozempic. And there's been a lot of people that are pushing back on Ozempic, that are saying taking Ozempic is removing the hard work that get people to the result. And while there's great benefits of taking those drugs in terms of what the conditions you reduce, if you're morbidly obese or whatever. But yeah, I feel like there's a similar sort of tug of war going on here. It's you want people to go through the challenge and deal with that challenge, but the ease to want to go towards, whether it's the medicalisation, the ease of the life that we live in, and whether there's actually technology that plays a role within all of this that's making it. I guess that was something we didn't actually touch on, was how much of technology masks a lot of these conditions and disorders, in terms of where do you draw the line between actually technology playing a role in creating us as being more distractible and having less attention, and actually then slipping it into a disorder. But I guess it's subjective.
Yeah, I get the technology argument, and it must have had an impact because it's introduced a whole new set of dimensions that we didn't have when we were growing up. So it's meant a number of things that are potentially difficult and harmful, such as easy access to inappropriate material, whether that's sexual or violence or whatever. And also things like, if you're being bullied, you can't leave it at the school gates because it will follow you online. And easy to say, well, just get offline and don't pay any attention, but that's very hard. Then all your peers are doing it. So there are all these aspects which, as well as the whole thing of the way social media, for example, is set up to collect data. So the longer it can keep you on, the better. So it can be something that is distracting you from all sorts of other ways of engaging. There is another aspect, though, that one of the things that's happened is a process that's been referred to as the domestication of childhood. So the domestication of childhood basically points out that children growing up in the last 30, 40 years are getting less and less time away from adults who are supervising them. So whereas previously kids would have formed their own football teams and maybe took on a rival football team just in the park and put a couple of jumpers down for a goalpost, and now they're organized into leagues with adults training them from 7 years old, and they'll have their Sunday matches, and the adults will line up around, and you'll see. I've had my son involved in that, and I've seen parents fighting each other, you know, living their own failed dreams through their kids. So there is that whole process. So one thing that I sometimes wonder is that kids have much fewer opportunities to have a setting where they can create something I would refer to as kid culture, stuff you're doing that adults don't know about. And I think there's something probably quite valuable in having a bit of kid culture as you're growing up. And I wonder sometimes if on the online world, in WhatsApp groups or in other social media settings or just emails or whatever it is, texts, is giving an opportunity for a place where some kid culture can occur. So I also think we have a tendency to exaggerate the impact of new things. So it used to be the case that TV was going to rot children's mind and they were going to sit up, and then it was like 24-hour TV. Oh my God, which does have some validity to that. So I think we have to be careful not to exaggerate. One thing I do blame social media for is it is not the cause of these concepts, because these concepts have been developed within, psychiatry, psychology, psychotherapy, etc. But it has provided a forum for, if you like, social contagion of these concepts. And once it's spread wide, you have all these influencers who talk about, oh, I've got, this condition, that condition, and other people are watching it and, oh, yeah, that sounds like me. So it's allowed for these conditions and therapy speak and concepts to escape into the wider culture.
That for me is a big part of it, is the
Yeah.
placing of a lot of the I would say the other side of this arc, which is having people who are showing resilience, showing the way of being adaptable in the world, and maybe moving more towards whatever normal might look like, is that those people used to be revered, and we've now created a world where influencers are being revered for having this diversity, for having this neurodiversity, and all of those diagnoses it's creating that learned helplessness within people, creating the inability and incapability to deal with life. And then young people looking at going, well, if I can get those followers, I will be as revered by them for having what they have, so therefore I'll have it. And it
has glamorized
totally
certain conditions, and that's fine if you're you're successful, but for most people that's just glamorizing something that is not going to lead to that sort of success. It's not going to lead to an enhanced self-image. It's not going to lead to improved it's going to lead you down the rabbit holes that we've been talking about.
Yeah, pick your mentors wisely.
Yeah.
Sami, thank you so much for your time. This has been a brilliant conversation. I'm so glad I was able to have it with you. Where is the best place to send people to follow what you're up to? I know you're moving into retirement, but to find your book, find your work, where should we send them?
I have a website. It's Sami Timimi. That's SAMITIM for mother, M for mother, I. Sami Timimi .co.uk. So I have a website that I've got copies of things on there, things that I've written, podcasts that I've done. I am trying to get active on social media. I've tried to avoid it for years, but when I published, because I previously published academic books, so this is my first trade book, as it were. So I am, I think if you just look Sami Timimi, you'll find me on X and Instagram and now TikTok.
Fantastic. Sami, thank you so much for your time. I love what you've done, and I really appreciate you.
Thank you for inviting me. It's been a pleasure.
If you enjoyed that episode with Sami and you want to enjoy even more of the show, then you can get started with a playlist that I've put together, some of the best ones to get started with. All you have to do is click right here.